Welcome everyone to the eMedica GP update. This is the second session, and this time we're covering the new combined asthma guidelines. So for those that haven't met me before, a very brief introduction. My name is Muhibbur Rahman. I'm a portfolio GP, which means I'm a GP with multiple roles. So my clinical roles, including being a partner in my own practice. I also cover 2 different community detox units. And up until very recently, I was one of the GPs at a secure unit for women with significant mental health illness. My non-clinical roles primarily now are with eMedica, where I'm the medical director and I help to develop and deliver teaching and training, but I also work as a consultant in medical education and advise various other organizations, help deaneries support their trainees to get through their MRC GP exams. I'm an author on GP careers, on MRC GP, and I sit on the NICE GP reference panels, which gives feedback on guidelines that might impact general practice before they are finalized and published. And our team at eMedica have, since 2005, now trained over 82,000 delegates. Okay, so for those of you that are joining for the first time, welcome. For those that joined last time, welcome back. So today, what we're going to go through is we're going to start with a clinical update to cover the new asthma guideline. Then we will continue that learning on the same theme, but look at some practical consulting tips and have a bit of a demonstration. And finally, we'll finish with a Q&A. So in terms of the clinical update, we're going to focus on the new combined asthma guideline. So many of you know that previously there was one NICE guideline and a signed British Thoracic Society BTS guideline, and they had some things that were similar and some things that were different. And a really common question I used to get for doctors who are sitting for exams is, which one should I learn? And the examiners used to say, you should learn both because they were both in common usage throughout the UK. But they've been working on a combined guidance for several years. It was actually due to be published in 2020, but then COVID derailed and delayed things significantly, but it finally came out November 2024. So there's key changes both for diagnosis and management of asthma. And asthma is one of those conditions that, if you're working in GP, probably most days of the week, you'll have at least one patient that you're seeing who might be suspected to have asthma and you're working up the diagnostic pathway, or maybe is having an asthma review, or has had an exacerbation, or has come to talk about the fact that they're either thinking of stepping up or stepping down their treatment. It's such a common and important condition, isn't it? And for patients who've got asthma, if it's well managed, it can make a huge impact to what they can do in their activities of daily living, in their exercise. And when it's not well controlled, it can have a huge impact, detrimental impact. So it's a really important topic. So it's very interactive today. Please use the poll to answer the question. So the way we're going to learn is I will show you some questions. So for those of you doing exams, the MRC GP exams, they're in a similar format to the questions that you might get in the exam. But for those that aren't, it's a useful way to test, have I got my head around this guideline? And some of you may not actually have had a chance to read it yet. Don't worry, we've summarized it, some hopefully clear to understand diagrams, and we'll go through it by the end of today. We'll go through all of the key parts in it, but we'll learn through questions and then I'll do a rapid review. So let's get straight into it. We're going to start by looking at a question on diagnosis. Okay, so let's have a look at this. I'm going to give you about just under a minute to have a look at this, about 55 seconds, then I'll launch a poll. Here we go. Okay, time's up. I've launched the poll. I'll give you a few seconds to select your answer. While you're doing that, just a quick reminder of the scenario that you've just read. So essentially, you've got an adult patient. That's important because the diagnostic criteria are different for adults and children. And even within children, the age matters. So they're 19. And you can see they've got symptoms that fit with asthma. So we're sending them for objective lung function tests to confirm the diagnosis. So one of those tests is FeNO. Type into the chat if you know what FeNO stands for. And what we're looking for is what's the threshold to actually confirm a diagnosis. All right, so in terms of the answer options, the two popular answers, the most popular one is C, 40 parts per billion, followed by B and E are the other two that were very popular. But the most popular one by a significant margin is C, 40 parts per billion. Okay, so the correct answer is E. So just under a quarter of you got that right. So most people didn't get this right. The most popular answer, as I said, is C. And for those of you that picked that, don't worry, there's a good reason why you picked that. 40 parts per billion was the threshold in the old guideline. It's been changed, that's why we're covering it, okay? In the new guideline, the threshold for adults and 17 plus for the diagnostic purpose is considered adult is 50 parts per billion. It's increased. So the old threshold for 17 plus was 40 parts per billion. So if you just haven't had time to read the new guideline, it's only very, very fresh. It's not even been 2 full months yet since it was published. That's okay, don't worry. Okay, that's why we're here today, right? 35 parts per billion, which was the other popular answer, that's actually the threshold for children aged between 5 to 16. And that hasn't changed. That was the same threshold in the old guideline for 5 to 16. It stayed at that threshold. But for 17 plus, this was the old threshold. The new threshold is 50 parts per billion. Okay, so let's go through what are the positive test thresholds on this objective lung function test. So FeNO stands for fractional exhaled nitric oxide. So basically, this is a sort of quite relatively new. It's been used since the old NICE guideline. So, it's been around for quite some time, but relatively new if you think about how long we've been diagnosing and managing asthma. But basically, it's a useful aid to have an objective measure to diagnose asthma. So what it does is you have these FeNO devices. They measure, when they're breathing out, the amount of nitric oxide in the breath of patients. And that's a biomarker for asthma, basically. So it can give an indication of the level of inflammation in the lungs. So 35 parts per billion of FeNO in that exhaled breath is the threshold for children aged 5 to 16. Under 5, you can't use these tests. You basically look at symptoms, and then there's a way that you can make a diagnosis. We'll talk about that later, okay? But for older children, 5 plus, and then for 17 plus, which for the diagnostic purposes is considered an adult, it's now 50 parts per billion or more. That's the new threshold since the new combined guidelines. Then you've got bronchodilator reversibility testing. So here, if you've got 17 plus, you're looking for two things. That the FEV1, so that's how much air they breathe out in the first second of breathing out, is at least 12% improved from when they, you do it before they have the bronchodilator, then you give them the bronchodilator, you wait about half an hour, then you do it again, right? So you're looking for at least 12% improvement, all right? Or 10% or more of predicted FEV1, either predicted based on their age and gender and height and things like that. As well as that, so the FEV1's got to improve, but you've also got to have an increase in volume, so lung volume, of at least 200 mils. That's for 17 plus. For 5 to 16, you don't need the increase in lung volume, and that's because in this age range, the height can be significantly different, so the lung volume is going to change a lot anyway, from when someone's 5 to when someone's 16. By the time someone's 17, they're reaching their peak height, and it's enough that you look for this 200 mil increase. So for 5 to 16, all you're looking for is that improvement in FEV1, or that 10% or more of the predicted FEV1. Then another alternative is peak flow variability, at least 20% variability. And then finally, direct bronchial challenge. You can use two things for this, either histamine or methacholine. The threshold is the same. You're looking for a PC20 of 8 milligrams per milliliter or less. Most of these were all in the old guideline. What's changed is the threshold, the adding of the 10% of predicted FEV1 as an alternate, These two haven't changed. This is new, completely new in the new guideline. And that is that if you've done all of those and you're still not sure, then you might think about skin prick testing. So you're looking for house dust mite or IgE levels and eosinophil count for 5 to 16. So if the skin prick test is negative and IgE is not raised, then that's a negative confirmation of asthma. If the skin prick test is positive or the IgE is raised, then you also need to look at the eosinophil count. And if that's also increased more than 0.5 times 10 to the 9 per liter, then that's, in the new guideline, a confirmed diagnosis of asthma. Okay, this one isn't done routinely. You'd normally start with this and potentially this. As part of doing this, if you're going to do bronchodilator reversibly, you're doing spirometry. So you'll also check this. If these don't give you the answer, then you might move on to direct bronchial challenge. If that doesn't give you the answer, then you might go on to skin prick testing and IgE levels. Okay. You wouldn't routinely do that for everyone. Right, let's look at asthma in children in terms of, I mentioned that under 5, you can't use those diagnostic tests. Great. So the two popular answers are C and D. So consider an 8-week trial of low-dose steroids or moderate-dose steroids at the pediatric low or moderate doses. These are two popular ones. The third popular option is refer to a specialist respiratory pediatrician. Very few people picked A or B. All right, so that's good because the objective lung function tests that we can do in older children and adults are not things that we do in under 5s. So what we've got is a 3-year-old where we're suspecting asthma based on the symptoms. The correct answer is C. You'd think about doing an 8-week trial of putting them on a pediatric low-dose steroid. You're not putting them on that as a long-term management. You're actually putting them on that as a diagnostic tool, because what you want to see is what happens when they go on to a low-dose steroid for 8 weeks to 12 weeks. How do they respond? Because if they respond well, i.e. the steroids make a big difference to their symptoms, that is sort of confirming your diagnosis, because what it's showing is a degree of reversibility. Okay, the fact that it changes. Okay, I'm going to do a second question and then I'm going to go through the guideline for under 5s. Okay, so let's do the follow-up question, 55 seconds. I'll stop you there. So much bigger spread of answers now. So B, C, and D. So starting Montelukast, doing a trial of moderate dose steroid, or referring to a specialist respiratory pediatrician. All 3 of these were very popular. This one slightly more so, but these 2 are very close behind. Okay, so what we've got in this scenario is slightly different. You've got someone who been to the hospital 3 different times in a 1 year period because they've been wheezy, and they've been put on a trial. Remember, we used the trial in this age group as a diagnostic test. So they've had a trial for 12 weeks of pediatric low-dose steroids, but look at this. Their symptoms didn't improve at all. There's no obvious triggers. There's nothing else that we can think that fits. So the correct answer, according to the guideline here, is to refer to a specialist respiratory pediatrician. That's because we basically don't have an explanation if we can't think of another diagnosis apart from asthma, yet they haven't responded to steroids. We've got diagnostic uncertainty. They're going to need a specialist workup by an asthma specialist to come up with what is the actual diagnosis. So that's why it's D. So now let's go through the guideline for under fives. So you've got someone under 5. Remember, you can't do those objective tests like FeNO, like spirometry, like the methacholine or histamine challenge and so on in this age group. So if you've got someone with suspected asthma and they've got symptoms, they're getting really wheezy, they're getting short of breath, maybe they're having nighttime cough, things like that, or they're getting severe acute attacks, ending up in hospital. As a diagnostic tool, you basically put them on a trial of pediatric low-dose steroid, at least 8 weeks, up to 12 weeks. If their symptoms don't improve, check are they using the inhaler properly. In this age group, it'd be the parents giving it generally with a spacer. Check the environment. Could there be a trigger causing, some kind of other allergic type reaction? What's going on? Consider any other differentials. If there isn't anything else that comes out, then we don't have an explanation for why the treatment has failed. So you'd refer to an asthma specialist. You see, that was this last patient. We'll go down this pathway. Whereas if their symptoms resolve, then your diagnosis is basically confirmed that, okay, we've got someone here, this fits with asthma. All right. So you'd consider actually stopping after the trial period to see how do they get on now that we've confirmed they've got asthma, but we're not putting them on any regular treatment. And if their symptoms start coming back or they get even one severe acute attack, you basically say, okay, they need long-term maintenance treatment for their asthma. So you put them on a pediatric low-dose steroid. And alongside that, they have SABA, so salbutamol, which they take on a PRN basis. So this they're taking every day, a brown inhaler, pediatric low-dose steroid. Take this every day, morning and evening. If you get short of breath, take some extra puffs of your blue inhaler, the salbutamol, okay? And you just keep monitoring how they're getting on. You might titrate up to pediatric moderate dose steroid, all right? And if they, depending on how they get on, you might then consider a trial without treatment. Let's say, they're on low dose, their symptoms sort of clear up completely. You reviewing them every few months, 6 months in, you think, they're doing really well. Right, let's try a trial again without treatment and see what happens. If they're, okay, you might then step down. They might just stay on a SABA. If they're not well controlled, or if they're on treatment, they're taking it regularly, and they're still not well controlled, you've gone from low dose to moderate, then the next step is to add in a leukotriene as well. So they'll be on a pediatric moderate dose by now, and you put them on a leukotriene, so montelukast, and then they've still got the SABA, the salbutamol, to use PRN. That's there alongside, okay? If it's still not controlled after that, you'd stop the leukotriene and refer them to an asthma specialist. So for under 5s, it's relatively straightforward, okay? So let's look at the next age group, which is for treatment. Interestingly, it's slightly different, the age groups, compared to diagnosis. Remember, for diagnosis, it's under 5, 5 to 16, and then 17 plus. For treatment, it's under 5, then you've got 5 to 11, and then you've got 12 plus. So let's look at the next age group. Here we go. We're going to do the second question, and then I'll launch the poll after. We'll go back to the first one, because if I explain the answer to the first one, it might give away the answer to the second one. Right, okay, so what I'm going to do is I'm going to go back to the first one in this set. So this is an example of an extended matching question for those of you that are doing the MRC KT. So remember the two common question formats: single best answer, like the ones we did before. Extended matching questions come in sets of 2, 3, 4, or more. Within the set, the answer options stay the same. What changes is the actual scenario and the question. Okay, so this is the first one. What we've got here is a 10-year-old, and you can see that their symptoms are really poorly controlled. 4 times a week, they're getting up in the night. This is despite already, being on steroids. So they're assessed as, can they manage a MART regime? And one of the things is, some of you might not be familiar with some of this terminology. You might think, what's this? Why haven't they explained it? Because that's part of what they're testing. They expect you to know what this is. So we're going to look at some of the new terminology. Okay, so what's the most suitable next step? i.e., they're not well controlled on steroid, and they can manage a MART, and they're 10 years old. This is all important. The correct answer is to offer them a pediatric low-dose MART regime. Okay, let's look at the second one in the set, and then I'll go through the guideline for this part. So this one's an 8-year-old, and they're having to use their salbutamol nearly every day, despite being on steroids. You can see they've tried montelukast before, but it didn't get on well with them. And we've assessed that they're not able to manage a MART regime. Type into the chat, why might a child of this age struggle with the MART regime? So the main thing is that especially in this age group, the only option for a MART regime is, the brand name is called Symbicort, but basically it's got, the steroid with formoterol. Anyone know which steroid is in the MART regime that you can give to children of this age? Budesonide, that's right. Now, in that combination with Symbicort, that's only available as a dry powder inhaler. So they need to be able to take a deep breath in, coordinate that at the same time they take. A lot of children can't do that. And so there are other options if they can't do that, which can be used with a spacer, with a regular inhaler, with alternate choices. All right. When we get to adult MART regimes, there's other choices for the steroid component. The LABA is always formoterol, but you've got other choices, because as well as budesonide for adults, you've got the choice of beclometasone. Okay. So the correct answer, if they can't manage a MART, is A. So a pediatric low-dose steroid in combination with a LABA and a separate salbutamol inhaler. Okay. So the actual drugs in this are the same as what's in the MART. What's different in the MART, though, is that you don't separately have a SABA, and you've only got, for this age group, that one choice, and it's got to be a dry powder inhaler. Okay. Whereas here, you could have a steroid, any steroid, with formoterol, and there could be a combination inhaler. That's usually what's given to make it easier, or it could actually be separate if you wanted to. Okay. So let's go through the guideline for 5 to 11. Do you notice the difference in age range? For diagnostic threshold, there's under 5, 5 to 16, 17 plus is adult. For management, it's under 5, 5 to 11, 12 plus is the same as the adult regime, basically, for management. Okay, so At the beginning, you've got salbutamol plus a pediatric low-dose steroid, for someone that needs regular maintenance therapy. Before that, they'd just be on salbutamol on a as-needed basis. And then what you do is, if they're not well controlled here, you assess, can they manage a MART regime? So could they manage one of those dry powder inhalers with the combination of, in this age group, there's only one combination, budesonide and formoterol. Formoterol is a fast-acting, long-acting beta agonist. So it's a LABA that's fast-acting. Okay. If they can manage it, then that's what you do, is you put them on a MART. So with the MART, they now no longer have a SABA, they no longer have salbutamol, they only have one inhaler. And the same inhaler, what does MART stand for? Maintenance and reliever therapy. So they just have one inhaler, which has got a combination of budesonide and formoterol. They take that in the morning, they take that in the evening. Or there are some regimes where it's just a once daily dose. But if they then get short of breath, they just take a few extra puffs of the same inhaler. There's no separate inhaler. So it simplifies things. But as I mentioned, not all children can handle a dry powder inhaler. And then if it's still not controlled, you just move up to a pediatric moderate dose MART. So it's the same drugs, it's just that the dose of the steroid is doubled. Okay, but it's still a combination inhaler. Still not controlled, refer to asthma specialist. If they can't manage MART, then it's a bit more close to the old guideline, but it's just that it's now one set pathway, whereas previously, for this age group, there were differences as to what goes first between NICE and signed BTS. So if they can't manage MART and they're already on a steroid, salbutamol PRN, the next step is add in a leukotriene. So they're on montelukast alongside the pediatric low-dose steroid. They've still got the salbutamol, so they take this regularly. They take salbutamol if they get breathless. Not well controlled, go to pediatric low-dose steroid with a LABA combination. So that was our patient, right? They tried leukotriene before, it didn't work. They were still on the pediatric low-dose steroid. Didn't work, you go to this. So pediatric low-dose steroid with LABA. You can see that's actually the same drugs that's in this, okay? You could keep the leukotriene if they tolerated it and it helped. You could stop the leukotriene if they didn't tolerate it, which was our patient. And then they have a salbutamol as a PRN basis. Still not controlled, you go to pediatric moderate dose steroid. So i.e. the dose of the steroid doubles and you still got the LABA. Again, if the leukotriene was tolerated and helped, keep it. If not, stop it. They've still got the salbutamol on a PRN basis. Still not controlled, now you refer them to an asthma specialist. Okay, so that's 5 to 11. So the last part of the puzzle, let's look at the adult guidelines. Here we go. So the split of answers is really interesting. It's almost equally split between D, E, and F. So confirm a diagnosis of asthma and either offer PRN air therapy or for a low-dose MART regime or for low-dose steroid plus PRN salbutamol. That's what a SABA is, right? So these three almost equal. Then a few people said confirm a diagnosis of asthma and just give salbutamol PRN. What's interesting is hardly anyone has picked A and B, which is good. It shows that you've already learned that part of the guideline, i.e. what's the diagnostic threshold for an adult. You can see if their FeNO levels are 55, that's enough to make a diagnosis. Because what's the threshold? Type into the chat. We covered this in the first question. Just let's consolidate it. 50, that's right. The new threshold is 50. It was 40 in the old guideline. For adults, it's now 50. Okay, so the correct answer is D. We've got enough to make a diagnosis, so that's the first part. So we can eliminate these two. Well done. So you confirm a diagnosis. And then the first step is to offer PRN air therapy. Okay, so let's do the next question, and then I'll go through this guideline and we'll go through what is. Actually, let's go through the guideline first. So you've got someone, in this case, newly diagnosed. Remember, the threshold 12 plus is now the same as the adult guideline. There's just one for everyone 12 plus. So children 12 and above and adults all have this guideline. So the first step, once you've diagnosed, is to go on to PRN air therapy. What is air therapy? It's basically, it stands for anti-inflammatory reliever therapy. The anti-inflammatory is the steroid. Okay. So PRN air therapy has the same exact components in the inhaler as MART, i.e., it's got budesonide and formoterol. That's for children. For adults, you've got other options. Okay, formoterol is still the LABA. You've got other options for the steroid. Okay. The difference is, remember with MART is maintenance and reliever therapy. You only have the one inhaler, but you take it regularly every day, and then you take extra puffs if you get short of breath. In PRN air therapy, you don't take anything every day. You only take it when you're short of breath. So instead of having as the first step, which was in the old guidelines for adults, having a salbutamol inhaler, a blue inhaler, which you just take when you get short of breath, and then only if you're having to use that a lot, you'd move on to steroid. As soon as you diagnose someone 12 plus with adult, you want to go straight on to having some kind of steroid. But they're only using it when they need it. And that's because of the anti-inflammatory impact, and the evidence is now overwhelming that this is so much more effective instead of having salbutamol, which does nothing. It gives you that short-term relief, but it isn't helping at all in terms of the long term. So PRN air therapy is an inhaler with a steroid and formoterol. Okay. So at this stage, it's a low dose, and they just take it when they need to, whenever they're short of breath, whenever they're a bit wheezy, or if they're having lots of nighttime cough, they just take the inhaler. If then it's not well controlled, they'd go on to a low dose MART. Basically, it's the same inhaler, but now they take it every day, regularly. And if they get short of breath, they take a few extra puffs of the same thing. So what's in MART and what's in air is the same thing. The difference is air is a PRN option. MART you take regularly, and then also PRN, just extra dose of the same thing if you get short of breath. In all of these options, do you see, there is no salbutamol anymore. There's no SABA. It's removed in the new guideline for adults completely. Okay, because anyone on MART doesn't need a separate salbutamol inhaler. You just take a few doses of the extra dose of the same thing, because the LABA, formoterol, is a fast-acting LABA. Okay, long-acting beta agonist. Okay, now if someone at diagnosis is really highly symptomatic, or they've had lots of really severe exacerbations, then you'd skip the PRN air therapy and go straight to having a regular MART regime. So straight on to take inhaler every day, morning and evening, and if you get short of breath, take extra doses of the same one. Not well controlled, the next step is moderate dose MART. So essentially, again, same combination, but the steroid dose doubles. Still not well controlled? At this stage, again, this is a big change in the new guidelines, because what you do now is check FeNO again and check their eosinophil count. If either's raised, refer them to an asthma specialist. If neither's raised, then you could trial either putting them on montelukast, so a leukotriene, or a LAMA, long-acting antimuscarinic, okay, alongside continuing the moderate dose MART. Still not controlled on that, refer them to an asthma specialist. So this is the guideline for adults. So let's do one last question relating to asthma in adults. All right, so the three popular answers are A, B, and C. The most popular one, about 70% of you picked B, offer PRN air therapy, but the rest was either re-prescribe and just keep going on salbutamol or offer a low-dose MART. So what we've got here, this is different. The other one was just diagnosed, remember? This is someone who's got asthma and they're on the old guideline. They're just taking salbutamol, and actually they've had that the last year, they've had the same inhaler. That suggests they're not really using it that much. They only had one exacerbation where they needed to have steroids, but they were able to keep going to work. So it suggests that it was a short course and it worked very, very rapidly. They're not had lots and lots of exacerbations. So what's interesting is in the new guideline, no adults should stay on salbutamol. So we should move them across to a PRN air therapy. So remember, that's a steroid with formoterol. In an adult, the steroid could either be budesonide or it could be beclometasone. In children, it's always budesonide and formoterol. In adults, budesonide and formoterol or beclometasone and formoterol. An example of that combination is Foster, for example. Okay. In children, it's Symbicort is the only option. Budesonide and formoterol is an example of that. So if we look at the last part of the guideline, which is rather than just looking at people who are newly diagnosed, is what if someone's already been diagnosed? So if someone's already got asthma and they were already diagnosed on the old criteria and they're 12 plus, if they're just on salbutamol, even if they're well controlled, you move them on to PRN air therapy because the evidence is this is much better for long-term outcomes. Okay, so that's this patient. They were fairly well controlled, only one exacerbation in a year. We're going to move them to PRN air therapy. They had salbutamol, and alongside that, they were already on maintenance therapy. So if they were on just low-dose steroid or low-dose steroid with LABA or low-dose steroid with leukotrienes, or a combination of all of those, but the steroid component was low dose, you move them to a low dose MART regime. So a low dose steroid with formoterol. If they were further down the old guideline, i.e. they were on a moderate dose steroid with any of those other combinations and using a SABA, salbutamol as and when, you scrap the SABA and you move them to a moderate dose MART regime with moderate dose steroid in combination with formoterol. Okay, so this is what you do when someone's already got a diagnosis in terms of how we transfer them the next time we see those patients to the new guideline. That's the last part of the puzzle, if you like. Okay, good. So what I'm going to do, just to summarize, and I'm going to answer some questions that people had. This is now the combined asthma guideline. It's slowly starting to be disseminated, but this will be the combined guideline that's used UK-wide, which makes things easier because you don't have to now remember two guidelines. It's one unified guideline. It's been long overdue. So remember that both the diagnostic criteria for children and for adults have had some changes. The biggest one being that for FeNO, adults has increased significantly. And then that we also have for people who we still got some diagnostic uncertainty, having gone through a lot of one, there's a completely new test, testing for dust mite allergy and eosinophils and things like that. But the biggest change is in terms of management. So in all age groups, there's been significant changes to the management algorithm. Remember, older children and adults, air therapy is the first line. There is no use of salbutamol anymore. There's no first step of PRN salbutamol. Whereas in younger children, and particularly very young children, you might see situations where they just get some benefit. And the first step in those slightly older children, they'll just be on salbutamol as and when. And then if they can't handle MART, they might still be on things that were very similar to the old guideline. If they can handle MART, then those older children will go into a MART. MART is never there for under fives. And just to remind that, guidelines are always changing. This is asthma, it's a major one, but recently we've had changes to the menopause guideline, OCD guidelines in review at the moment. We've had lots of guidelines change. The obesity guidelines were recently updated. So it's one of those things that, especially if whether you're sitting exams or whether, you're just seeing patients day to day, this is one of those things. It's important that we stay up to date. Okay. For everyday consulting, you want to make sure you're evidence-based, that you're doing what's considered based on research the best for your patients, but also for exams, they frequently test new guidelines. And just in terms of that, several people have asked, could this guideline come in the January AKT? Absolutely. It's one of the reasons we're covering it. So generally, the Royal College has a 2-month embargo, i.e., if a guideline changes within 2 months of the date of an exam, they'd consider it's too new and that it would be unfair. There might not be enough time for people to, read up on the changes, and they wouldn't normally ask a question on that guideline. But this guideline was updated the 27th of November, and the exam is on the 29th of January. So it's just over the 2-month embargo. So i.e., if there are questions on asthma in the January exam, I would expect it to cover the new guideline because it's more than 2 months. All right. Right. And then I'm just going to have a quick look at a couple of other questions on this before we move on to the next bit. Someone's asked a great question that, sometimes there can be different brands of inhaler. There can be, the names can be confusing. How can you keep up to date with that? It's an excellent website. It's called RightBreathe. Okay, rightbreathe.com. If you go on there, you've got all the different types of inhalers, spacers, and what you can do is you can either put in the drug class, the drug name, you could put in the brand name, and it will tell you what the different things are. So for example, if I was to type into here, Symbicort, okay, it will tell you what's in Symbicort. Okay, you can see it's an ICS and LABA, but it'll tell you exactly what's in there. So you've got budesonide 100 micrograms with formoterol 3 micrograms in the 100/3. In the 100/6, you've got budesonide 100 with formoterol 6 micrograms. Okay, you could have, for adults, remember that for their MART, they might be able to have other combinations, including beclometasone. So like Foster is an example of the brand name of that, beclometasone with formoterol. The LABA, by the way, in any MART regime, the fast-acting LABA is always formoterol. There isn't another one. But that's a really good website to find different inhaler names. Okay, it's quite useful, practically day to day. And then someone asked, what doses are low dose, medium dose? If you look, the BNF has got a nice summary of that, and the NICE guideline has got a nice summary of that. Okay, great. So let me move on then to, I've got 10 minutes left to do a little bit of practical consulting, and then I'll come back and answer any other questions that the team haven't cleared up. Okay, so practical consulting. Before we do that, just a quick reminder, the next 5 eMedica events. So we've got a couple of things coming up for those of you that are in training. 28th of January, we've got, for those that are already on our pass guarantee program for the January exam, remember that's the day before the last exam. That's our last higher revision webinar. 29th of January, which is the date of the January AKT, is actually also the orientation for those that are joining our 90-day AKT Pass Guarantee program. For those that haven't heard of our Pass Guarantee program, this is a very comprehensive, structured program for those that want to guarantee that they pass the AKT. How it works, the 90-day program, for example, is every day for 90 days, you'll get an email with daily tasks, set tasks, reading, questions, things to do. Alongside that, you get weekly tasks, which are different types of learning. Sometimes there might be a recording of a video session we've done before. Sometimes it might be an RCGP task. Sometimes it might be a research task to really deep dive into a guideline so you really understand it. Okay, but every day we send you work. There's daily tasks, there's weekly tasks, there's printed materials we send you. There's a whole load of live sessions. There's 10 webinars. There's, 2 full-day courses, half-day stats, half-day admin. But as long as you do all the work on time, attend all the live sessions, we're so confident that you'll be well prepared because the program includes over 225 hours of guided learning, and it's structured. You don't have to worry about what do I need to learn. Just do the work we send you. We will cover everything you need. We guarantee that you'll pass the exam. If you don't, you can either have a complete refund or you can join the next program free of charge. Okay, so the 90-day program for the April exam is starting on the 29th of January. Then the 5th of February will be the first one of those live sessions for that one. 12th February, we've got an MRCGP SCA intensive course, 20 live role plays, detailed individual feedback. You'll do a full mock case. You'll do some interactive cases. You'll get a chance to see other people getting feedback. We have a male and female professional simulator. You'll get feedback from me, very detailed and individual. And then after that, the 13th February is the next of the live sessions for the April 90-day program. And really, just to say that our team at eMedica now, I mentioned earlier, we've trained over 82,000 delegates. In our 20th year, we started in 2005. This August will be 20 complete years. And we've developed over that time expertise in helping people get into training and then get through their membership and then guide them post CCT. So, if you need support, whether it's AKT exams, SCA, you're about to finish or already finished, you've been qualified for several years, you're looking for a change, we have things to support people for every step of their journey, for GP training, GP exams, and GP careers. So you can find out details about that on emedica.co.uk. So let's have a look at this practical consulting. So you've got an adult patient, and they were previously taking, a beclomethasone inhaler morning and evening, brown inhaler, and they're taking a salbutamol inhaler, PRN. You see them for their annual review, and so you're changing them over to a MART regime. So think about how could you explain the change and what the difference is between MART and having a steroid and a salbutamol, PRN, in clear, understandable language. So if you think that you'd like to have a go at that, use the raise hand feature, and then I'll give you a chance to come on and have a go at explaining it. Great. Right, so Rami's going to have a go. If you just turn your mic on and we'll just do a quick check, just tell us, Rami, where you're working and if you're in training or already post CCT.
Hey, I'm Rami. I'm in training GPST3 in Cheetham Hill and in Manchester, and I only have the SCA left, but I thought I'd come and finally understand how to do the new prescriptions and the new asthma guidelines.
Good. Well, hope you found that helpful. Let's have a go at this then. So I'll be the patient, okay? And I'm going to ask you a question about this, and then you just go ahead and try and explain it in your own words, and then I'll try to have a go at it afterwards, and we'll see how we get on, okay? So, doctor, I don't understand. I've been using this brown inhaler and blue inhaler for years. So why do you want me to change to a different one? What is this? I've never heard of Mart before. I thought that's where you go shopping.
So recently we've had a review and change of our guidelines, and the evidence has shown that there's possibly a better way to control your symptoms, and it's also less cumbersome, less confusing. I know you're used to the brown and blue inhaler, but we want to change over to something that can do both. Something that you use every day the same way, say 2 puffs twice a day. But when things get bad, you can use it as your blue inhaler. So it'll be one inhaler to replace them all. Does that make sense?
Okay, but then if I'm really short of breath, can I still use my blue one as well?
No, this new inhaler, it replaces your blue inhaler completely because it has a very similar chemical to the one that's in your blue inhaler, except it works very fast. So we'd prefer if you use the new inhaler for everything. It's going to be just the same way you use your brown inhaler. You're going to use it every day. But if you ever get really short of breath, any extra doesn't come from the blue inhaler. It will come from this new, what we call it, MART inhaler.
Okay. Great. Well done, Rami. That was very, very good. So well done, and thank you for volunteering. Okay. So I'm going to have a go now. I'll turn your mic back off. Thank you. Okay, so that was really, really good. So one thing that I would add to that, I think you gave a good explanation of the fact that it's based on research. I think people, if you say, oh, the government guideline or something like that, people don't trust the government, right? But people trust science. So that using the word research, I think is really good. One of the things though is the patient said, I've never heard of MART. I thought it's somewhere where I go shopping, right? Sometimes just breaking down an acronym like that, MART stands for something, right? That can be really powerful. So I think that's the one thing I'd change to how you approached it. I think the explanation of how to use it, that if you're going to use it just like your old one, morning and evening, then if you get short of breath, just use extra puffs of the same one. I think that was really good. But I would add to that is just sometimes breaking down the words. So I'd say, look, you said you hadn't heard of MART. Perhaps it would help if I explain what it is. MART, M-A-R-T, stands for maintenance and reliever therapy. So therapy just is treatment, okay? So previously, you had one inhaler for maintenance. That was your brown one. So you take that every day, whether you're breathless or not. That's to maintain your control of your asthma, to try to prevent you getting short of breath in the first place. Then you had the blue inhaler was your reliever treatment, your reliever therapy. Your blue inhaler, if you got short of breath, you would take that. This is a maintenance and reliever in one. So it simplifies things. So you've got the one inhaler, you take it morning and evening. If you get short of breath, you don't need to worry, which one do I take? Especially if you're really unwell, you don't have to worry about maybe you're taking the wrong one. Sometimes people will take the brown one when they're short of breath just because they're out of breath and that's what's nearby. Here, you just have the one inhaler and it works for both. It's for maintenance, so to keep you in good control of your asthma, and a reliever when you get short of breath. And the way it does that is that it has something that will help to open up your breathing tubes when you're really short of breath, but it acts very fast. So it's a fast acting, but it also continues to work after you've taken it. You see, so you've explained exactly what it's doing, but you've also added that thing now that you've demystified the acronym. So they know what does MART or MART stand for. So hopefully that makes sense. We can use that technique in lots of other situations. If you're explaining to a patient, who's got benign prostatic hyperplasia, BPH, if you explain what does benign mean, what does prostatic mean, what does hyperplasia mean, now it's clearer to them, okay? And then also they might go up these days, almost certainly they're going to go and Google it. They've already got a clear idea of, where to start from, okay? So well done. I think you did a really good job. Just a small tweak, and we can just add a little bit of further things to just clarify that last bit. What does it actually mean? Okay. So just before we go, please do join the GP Training Support Facebook group for those of you that are still in training. It's the largest group of its type. It's over 40,000 doctors on there. Subscribe to our YouTube channel. Someone will post a link to that so that if you want to get access to this recording, but also you can look through, we've got lots of other, we've got the first session, which we ran last year. The plan is to run these every couple of months, okay? But also, I'd love to know what topics you'd like covered in the future. Please let me know in the chat. Is there a specific topic that you've struggled with or that you think, I'd find it useful to understand? But also let me know in the chat if this was helpful, if you feel a bit more confident now in navigating the new guidelines, both for diagnosis and management. If you feel, you still might need to read up the full guideline, but do you feel that at least it's a little bit clearer so that when you do read it again, you'll be able to put the pieces into the puzzle perhaps a bit easier. So our GP Training Support Group, the largest of its type, for people at any stage of training, but also for educators, people involved, GP trainers and so on. And then our YouTube channel, we've got over 260 videos now. We've got loads of things on there relevant for anyone at any stage of training, and there's also careers things on there. So any other questions? I'll try and clear those. For those that haven't got questions, thank you so much for joining. I do hope it's been helpful. Please do join us for the next one. Just to show you where you'll find on the eMedica website, at the bottom, we have what events are coming up. And so, both are paid courses, but also things like this, which are free. And, like there'll be a link like this. Once we've got a date for the next one, you'll just be able to click it to register. Okay. We'll send out an email beforehand anyway. Okay, great. So thanks very much. Have a great evening. Huge thank you to Anna and Laura for acting as faculty, and for the rest of the eMedica team that will do things like process the recording, send out the recording to people who've registered and so on. So thank you so much. Do subscribe to our channel if you want to get access to the recording. Like anything in life, prepare and you will succeed.